Hello, friends. Great to see you all. Thank you so much for joining us today. Really appreciate your time today. My name is Tim Brennan. I'm the Vice President for Medical and Academic Affairs at the American College of Academic Addiction Medicine, and I'm also the Addiction Medicine Fellowship Program Director at the ACAAM School of Medicine at Mount Sinai in New York City. I am joined today by the ACAAM President, Dr. Randall Brown, who also serves at the University of Wisconsin and wears a number of different hats there in addiction medicine and in family medicine. So we are absolutely thrilled to talk to you all today a little bit about what we think is a wonderful field of addiction medicine. Today is a high-level overview of addiction medicine fellowship training, why the specialty exists, what the training includes, and how it supports diverse career paths. Next slide, please. So why do we need addiction medicine physicians? In my opinion, I think the need is as important as it's ever been. And I'd ask you to consider what's going on in an emergency room right now. It could be any emergency room, perhaps wherever you are in the country. But a patient comes in and they have crushing substernal chest pain. It radiates to the left shoulder. They're sweating. They're acutely in pain and quite a lot of distress. When they come to the emergency room, they're met within seconds, literal seconds, by a triage nurse who puts them on a well-established pathway wherein they receive a series of evidence-based, peer-reviewed, high-quality tests and pharmacotherapy for what we all know of course, as an acute myocardial infarction. When the MI is diagnosed, and usually that occurs in the order of minutes upon arrival to the emergency room, at some point, inevitably, a cardiology consult gets placed. And the cardiology consult gets placed, and the cardiology fellow comes down to see the patient. And he or she doesn't come alone. They're usually trailed by a few internal medicine or family medicine residents rotating on cardiology, and inevitably a number of medical students. At some point, the cardiology attending comes down. She's board certified. She talks to the patient, and the patient's brought off to the catheterization lab, and if successful, has a plaque removal and goes up to a cardiac care unit. Several days later, after getting high quality evidence-based nursing care that's specific to cardiology, they go to a skilled nursing facility that also knows exactly how to care for cardiac patients. And the medical students go home kind of enraptured and enthralled by what they've seen. And they oftentimes want to go become cardiologists because they saw another life get saved by this important intervention. But of course, that's not the reason I'm telling you that story. I'm asking us to consider what's also happening in an emergency room right now. And that is that there are patients in other beds in that emergency room, sometimes in the dreaded hallway beds, that are there with substance use disorder. And there's hardly ever an addiction medicine consult service. There's very rarely an addiction medicine fellow, though we're looking to change that and have changed that to some degree. And sometimes there's no addiction medicine attending. The pharmacotherapy sometimes isn't evidence-based. Sometimes the interventions aren't evidence-based. And what we really see, unfortunately, is this heterogeneity as we look around the country. I practice medicine in New York City, and I promise you that if you show up at the 20-odd New York City hospitals with a substance use disorder, you will likely get 20 different standards of care. That's totally unacceptable. And it's on people like us, frankly, to change that. If you show up to 20 New York City hospitals with substernal chest pain radiating to the left shoulder, you're going to get the exact same care. And that's true whether you're at Mount Sinai or at the University of Wisconsin or UCLA or whatnot. It's very standardized. And our whole thesis is that fellowships in addiction medicine are the lifeblood of the specialty, and that all of that kind of academic rigor and research and peer review trickles down throughout the graduate medical education community into the undergraduate medical education world, such that the health system starts graduating physicians that know exactly what to do the next time those patients show up in the emergency room. Next slide, please. This is our mantra here at ACAAM to help meet the critical need for better integrating evidence based practice into treatment. Addiction medicine fellowship programs are dedicated to expanding the workforce of clinical experts, educators, researchers, and health system leaders trained in the latest scientific advances. Next slide. There was a piece published in the Lancet several years ago that looked at the so-called opioid crisis and the way we were responding to it. This was published in 2022. One of the quotes from it said that one of the most positive developments of the past 10 years is the 2015 recognition of addiction medicine as a medical specialty, which meant we were part of the American Board of Medical Specialties, which paved the way for a diverse set of physicians to receive additional training in addiction medicine. Fellowships should be expanded to increase the workforce targeting substance use disorders. To be clear, treat the patients that many times other clinicians don't want to treat. These are very complex patients, and we seek to kind of influence other systems of care by providing that evidence-based treatment. Next slide, please. The task before us is very great. To be clear, we have nowhere near the amount of addiction medicine physicians that are needed in this country. SAMHSA report from 2020 calculated that 41,000 additional addiction medicine physicians were needed to meet the workforce shortage. Next slide, please. We have grown considerably as fellowship training programs. If you look at our trajectory back in 2007, before fellowships were well established, we were known as the American Board of Addiction Medicine. And we were certifying physicians who took a board certification exam in addiction medicine. What we then did is start accrediting fellowships, which started to slowly spread around the country. But because we were not yet part of the American Board of Medical Specialties, our fellowships could not be accredited by ACGME. A number of transformative things started in 2015 and continued to the present day. The first of which was that we received formal recognition as a multi-specialty subspecialty within ABMS, where we're part of the American Board of Preventive Medicine as a subspecialty specialty within them. And that allowed us to then pivot our accreditation from the American Board of Addiction Medicine to the Accreditation Council for Graduate Medical Education, which we know of as ACGME. We now have 110 ACGME accredited fellowships spread across 42 states, including the District of Columbia and Puerto Rico as well. And we've graduated approximately 1,040 graduates through 2025. And then back in the fall, we completed our fourth successful National Residency Matching Program match during the 25-26 application cycle. Next slide. So to be clear, if any of you are kind of early on in your medical training, don't worry. You don't have to wait until fellowship to get involved in addiction medicine. There are a number of wonderful opportunities for you to join this field. For the medical students out there, there's a variety of electives and hopefully student interest groups at your school. If not, you should start one. Research opportunities, shadowing, advocacy work. We really need the voices of trainees throughout the trainee continuum to help influence policy, and also community work. I say that as a fellowship director. It's not necessarily particularly important to me whether you have papers published. I want to see kind of commitment to the work itself, which I think is even more important than getting your name on papers. For residents out there, perhaps there's addiction consult services that you can rotate on, or outpatient clinics, or elective work that you can participate in, or perhaps there's some scholarly work that you can get involved in. I would encourage all of you to reach out early. Addiction medicine is a highly collaborative, still pretty small field that is mostly relationship driven. So don't be bashful. Reach out to program directors on email. We're very outgoing and friendly group of people, and love to hear from trainees at whatever stage they're at to kind of guide your career. The good news is that you can train in whatever specialty you'd like prior to doing an addiction medicine fellowship, and we want to nurture that as well. A lot of people will ask us about addiction medicine versus addiction psychiatry. To be clear, addiction medicine is what we call a multi-specialty subspecialty, meaning there's a ton of different pathways into the field of addiction medicine. I personally trained in internal medicine and then pediatrics and then addiction medicine. Um, Dr. Brown trained in family medicine and then has pursued addiction medicine. So we all start as something else before we enter the field of addiction medicine. In addiction psychiatry, wonderful specialty, but they are a single subspecialty for psychiatrists. So unless you complete a psychiatry residency, you can't complete an addiction psychiatry fellowship. At my institution, at Mount Sinai, we have both programs. And if you came onto our unit, you probably wouldn't be able to tell the difference between the addiction medicine fellows and the addiction psych fellows. But they're two wonderful fields. But consider addiction medicine kind of the kind of broader field that has many more pathways into it. Next slide, please. So we recently, as I said earlier, completed our fourth round of the National Residency Matching Program. We participate in what's called the Medicine and Pediatrics Specialty Match. 101 different ACGME accredited fellowships participated in the program. And there are about 215 training positions filled for the upcoming 26-27 training year. If any of you are interested in getting a spot for this upcoming cycle, there are a small number of positions that remain available, and some programs will consider off-cycle training schedules. So check out our website for a current list of places, and certainly reach out to program directors if you are interested in that type of work. The process is very structured, and we are part of the main med-ped specialty match. So it's kind of built into your regular residency continuum. Next slide, please. The timeline for the applicants, at least for the folks starting July of next year, 2027, will be that the ERAS service opens in July, as it does for all the other med-ped specialties. And the interview season and match process basically goes from August through November, wherein you'll go on likely virtual interviews with a variety of programs, and then participate in the ranking process. And then the match day is slated for December 2nd of 2026 for a 2027 start date. You can check out the website link there for more information about the upcoming match. Next slide. We do a number of different things here at the American College of Academic Addiction Medicine around building the addiction medicine workforce. We have a very robust and substantial national didactic series wherein we come together on Wednesday afternoons and share didactics across our field, which means that the trainees from Mount Sinai learn alongside the trainees from Yale and Wisconsin and UCSF and Stanford, et cetera. We have a number of career and faculty development sessions for our members. We have a longstanding and very real, tangible focus on equity and inclusion. And we are committed to anti-racism, diversity, equity, and inclusion in our action plan, which I encourage you to check out on our website. We feel comfortable saying those words here in 2026. Workforce development is another big priority for us. We have a thesis that we are not going to see an increase in the workforce unless we have high quality fellowships spread around the country. That is the only pathway now to board certification. And so we very much want to develop fellowships alongside the programs in order to start graduating fellows and really helping with the workforce shortage. Next slide. So you can go on the ACGME website and look at the various elements of an addiction medicine fellowship training program. But to be clear, there's a number of different things that you're going to do. There's, of course, clinical depth and a variety of different rotations that you'll go on, whether it's on the wards as a consultant or in the inpatient detoxification units or in opioid treatment programs. There's, of course, protected learning time and mentorship opportunities. And programs, I would say, in addiction medicine tend to be a bit more heterogeneous than residency programs. Residency programs are bit of a cookie cutter framework, which is deliberate. We don't want residents graduating from programs in Cincinnati to be entirely different from residents graduating programs in Atlanta. We need to teach everybody the same topics. When it comes to addiction medicine, though, because our care programs look different as we go around the country and we all evolved around a different timeline, fellowships are a bit more lenient as far as the framework goes. So as you look around at fellowship programs, don't be surprised to see them looking rather distinct from each other. There's a lot of different paths through addiction medicine fellowships, but it's built on the same foundation, and you're going to get a great education no matter where you go. Next slide, please. As I said earlier, we are a true multi-specialty subspecialty. Addiction medicine fellowship training is open to anybody from all of the primary specialties. The eligibility is based on completion of an accredited primary residency, no matter if it's family medicine, internal medicine, pediatrics, ENT, emergency medicine, OB, etc. Fellowship programs value your demonstrated interest in addiction medicine. And I want to say, as a program director, that I recognize that demonstrating your interest is hard to do if your institution doesn't necessarily have interest. So I recognize that, and I am comfortable with trainees expressing that interest in a variety of ways. We, of course, value commitment to patient care and systems improvement if that's possible, but there's no single right background here for our trainees. We are not cookie cutter. We are looking for passionate folks dedicated to caring for this population. Next slide, please. We do a number of things during the fellowship year. We're looking to graduate fellows who are able to take part in advanced clinical care across a variety of care settings. We're very mindful in addiction medicine that the physician is but one member of the interdisciplinary care team, which oftentimes is comprised of nurses and pharmacists and counselors and other folks with mental health credentials, and oftentimes, importantly, comprised of people with lived experience, which are sometimes referred to as peers. Fellowship training provides the depth and longitudinal mentorship beyond these kind of short-term courses and certificates, such that you'll graduate with a really robust education and hopefully can pursue what are really a variety of very diverse career paths across addiction medicine. We are not like other fields. Our jobs look very different, and a lot of us practice in a lot of different hybrid places. And so if that type of work resonates to you, you're in the right place. Many of us also still practice our own primary specialty. I still work in the children's emergency room, and I love it. It's part of who I am as an identity as a pediatrician, and it's important for me to continue that work. So I don't want you to think that you're leaving your primary specialty. Many jobs these days allow for some flexibility. You can always moonlight, of course, and adding on this credential in addiction medicine doesn't necessarily close the door behind you from your primary specialty. Next slide, please. Okay, so addiction medicine fellowships are 12 months in duration. You could do up to 24 months if you're doing them part-time. There's at least 9 months of clinical experience. In order to match into a addiction medicine fellowship, you do need to have completed an accredited primary residency, whether it's an ACGME residency or ACGME International residency, or perhaps one accredited by the AOA, or up in Canada, either via the Royal College or the College of Family Physicians of Canada. And then we offer board certification, depending on your background, via the American Board of Preventive Medicine or the American Osteopathic Association. Next slide, please. So in your addiction medicine fellowship program, you will do at least 9 months of clinical rotations, likely more. 3 of those months need to be a structured inpatient experience, but that inpatient experience can be look a little different depending on where you are for fellowship. So, we have an inpatient addiction treatment unit at Mount Sinai, but other programs may have an addiction consult service, or perhaps you're going to the emergency department to do consults. Other programs may have medically managed residential programs or hospital based rehabilitation programs. As long as it's structured inpatient experience, it will count towards your fellowship training. And these experiences, of course, are focused on people going through oftentimes acute substance use withdrawal syndromes, often with comorbid medical and psychiatric issues as well. This inpatient training builds comfort with acuity and medical complexity. Next slide. Outpatient care. The same is true on the outpatient side, at least 3 months of an outpatient experience. And this may look a little different depending on where you are. Perhaps it's in a so-called IOP, an intensive outpatient program, or a day program. You may be doing addiction medicine consulting within an ambulatory care program, like a primary care clinic. Perhaps you're running a pharmacotherapy clinic. And this is where you're kind of embedded within the treatment team. And honestly, where most addiction medicine care happens. It doesn't happen in hospital settings, it happens in clinics and so on. And you'll be enmeshed in that framework. Next slide. No matter where you train, you will have a required so-called continuity experience. This is at least 1/2 day per week for the full 12-month continuum of your fellowship, in which you'll provide ongoing longitudinal care to a panel of patients with addiction disorders. You may be serving as the consultative addiction medicine physician, or you may be providing comprehensive primary care for patients who also have substance related or co occurring conditions. But no matter what rotation you're on, this continuity experience is embedded within the clinical training. It's not a separate block of training. And again, it runs for the entire year. And ideally, this is where you're going to see the recovery as a process, and you're going to see patients kind of grow into their sobriety. Next slide, please. Likewise, no matter where you train, as part of your fellowship training, you will have at least 1/2 day per week for the entire 12 months devoted to a longitudinal learning experience, which might include scheduled didactic sessions, probably part of the national didactic program that we run here at ACAAM, but could also include small group or individual tutoring sessions with your program faculty, or even self-directed learning activities that are mentored from your program experience. This is that kind of intentional space to step back and think about all the work you're doing, as opposed to being constantly doing things on the wards and in the clinics. It's really self-reflective time to add on to your learning. Next slide, please. So, our recommendations are that you engage early and seek exposure at whatever current stage of training you're at. Reach out and talk with addiction medicine faculty and fellowship program leaders, and apply very broadly and focus on program fit. It's 1 year. It's a great opportunity to spend that year in a different place maybe than where you're training. And again, fellowship adds a subspecialty. It doesn't make you lose your primary specialty. You're always going to be that initial physician. Next slide, please. Here is a map of our 110 ACGME accredited addiction medicine programs. Again, I will point out that you can't quite see Puerto Rico on the east, but we are as far east as Bayamon, Puerto Rico, and as far west as Honolulu, Hawaii. You see, we've got some work to do in Montana, Wyoming, and the Dakotas, and Texas as well, frankly. But there are a lot of fellowship programs out there, and we encourage you to apply broadly via ERAS, which allows you to do that. And these days, with virtual interviews, you can kind of travel around and check out a bunch of programs without leaving your desk. Next slide, please. So, As far as your careers go, there's a number of different roles out there for folks. Our graduates pursue very diverse careers with very meaningful impact across health systems and communities. Many of our graduates stay in academic addiction medicine. Completing a fellowship program is actually a risk factor for starting a fellowship program somewhere else. There are a lot of different health systems that are interested in scaling their addiction medicine service, which oftentimes begins with an addiction medicine consult service. That vignette I shared earlier about the emergency room is going to go away someday, thanks to addiction medicine fellowship graduates. But we get put in a lot of different roles, and many of us find ourselves in rooms with legislators and other elected officials to help impact substance use policy. Our field is kind of inherently a political one in the sense that the work that we do oftentimes kind of ties in with public policy, public health, and even politics. So, if that's of interest to you, you're certainly most welcome in this world, because we really feel like it's our job to kind of speak science to power and make sure that folks who are making these substantive decisions about health policy and drug policy really understand the evidence. Next slide, please. Ah, here's a little movie for you.
I love working with teenagers and building a relationship with them and working with them on navigating substances and how to build up coping skills in order to help keep them safe and healthy.
It allows us to change teenagers' trajectories in their lives. We get to meet them so young and get to teach them about how substances affect their daily life, but also how it affects how their brain develops and affects the rest of their future.
It's been an amazing experience getting to work on multidisciplinary teams, and I implore anyone who takes care of young people in the clinical or non-clinical setting to learn as much about substance use in this patient population as can have such a positive outcome on the health and well-being of our adolescent population.
It allows me to take care of very marginalized and stigmatized people. Like many of you, my own family has been touched by addiction, and the opportunity to care for folks who struggle with substance use disorders is of deep personal significance to me, and it's fun.
One of the most special things to me about being an addiction medicine provider is the role that we get to bring with curiosity and how it can become a tool for compassion when we get to walk with people on their complex journey in substance use care.
Number one is the patient stories. So in addiction medicine, we get to help people at their darkest and lowest points, and we get to follow them over time and see them get better. As a primary care doctor, my clinic's full of patients who've been surviving and thriving despite their substance use for several years.
I learned so much from the patients, and that was probably the most surprising thing to me. Was we would talk to them and they would teach us about how they did wound care. They would teach us about how they use substances and why, and the different times of day they would use different substances. And so I just felt like I learned so much, and it was just really a great experience so far. So I'm excited for more.
What is fascinating is how interested I am in continuing to work in this area and to help the treatment of addiction join the mainstream of healthcare so that it's no longer treated over there and by other people, but it's part of medicine. It's part of what all doctors do.
Thank you for watching that. We have a career stories video series, a YouTube playlist that features inspiring personal stories from addiction medicine professionals. These short videos highlight our journeys into the field and the factors that influenced our decisions, and some tips for exploring fellowship opportunities. Check out the QR code or go to the ACAAM.org website for exploration later. This is totally optional, not required, of course. Next slide, please. So we'll get into some Q&A now. And thank you for those of you that have submitted your questions. I am going to go into those questions first. Many of the questions, by the way, fall into common themes around the application process or career paths or broader questions about addiction medicine programs. The first question is, what differentiates a good versus exemplary addiction medicine applicant? You know, it's not cookie cutter. I have had wonderful fellows join me who have never once rotated in addiction medicine because they don't have it at their institution, and that's okay. That's not going to preclude you from matching. So I'm looking for folks who have documented their interests, whether it is that they presented a poster at an addiction medicine conference, even if it's a small local conference in your own area. I recognize not all of us have funds to go to national conferences or time, frankly. But I'm looking for that kind of spark that gets demonstrated. Another question was asked about what is the difference between the two application timelines for fellowship as it relates to addiction medicine? I'm not totally sure about that question. Please drop it in the chat if you asked that. But we are on the med-ped specialty match. And so that timeline kind of happens in the fall, early winter each year. And the applications open in July. The next question is says, I plan to apply for addiction medicine fellowship this July. However, I have a concern. Are there waiver jobs available after fellowship? And I'll bring Dr. Brown here on this as well. I would say there's a variety of different jobs out there. I assume you're talking about a visa waiver. I have had fellows in my program participate in that, but want to also turn things over to Randy to see if he has thoughts on not just the waiver job question, but the earlier question about kind of good versus exemplary addiction medicine applicants. Randy.
Yeah, no, I think you really covered that nicely. I mean, I like to see that someone has taken some initiative around exploring that as an area of interest. And so, there's some demonstration of interest. But to your point, it's something that's not universally available, as a well-formed rotation. And so we definitely take that into account. But some demonstration of that interest and passion, I think. I also have an eye to some, work with the underserved or some interest in that. We see a lot of, those sorts of issues by way of health equity and social justice in our population. So I appreciate that as sort of an interest. And one thing that's always, kind of difficult to tease out over the course of a fairly brief application period, you've got your personal statement and some interview time, but communication skills are so important with this population, and being able to communicate verbally and with compassion, I think, is something that we try to suss out, but can be a challenge. And we'll see that some in their recommendation letters, comments on collegiality and patient satisfaction, things like that are some of the things we look for. So far as waiver and visa support, that's going to be something that varies a lot by institution. And so I really encourage you to have that question on radar by way of exploring that at different programs that you might look into, because that's going to be something where there's going to be variation geographically, for sure.
Thank you, Randy. The next question is, can I apply to addiction medicine fellowship without prior residency training and also without step 3 as an IMG? You can apply. I would say it's unlikely that you'll be successful. And remember, while there are technically some pathways into like not doing a residency program, that has lifelong implications on your job prospects that oftentimes excludes you from working in numerous states. So be very mindful of that. Next question, maybe I'll pass it to you, Randy, is there a preference for research versus community involvement to highlight interest in commitment to addiction medicine for applicants?
That's a great question. And, I may have a slight bias around research because a lot of my time is research. But to be honest, a 1 year clinical fellowship, you saw the schedule, that's pretty demanding from a clinical standpoint. So over our 15-ish years of fellowship here, there is a requirement over the course of that fellowship to participate in scholarly activity, but that's quite broadly framed. And I tend not to encourage folks to be thinking about designing and carrying out a research project from start to finish during the course of a busy 1 year fellowship. If research is sort of an area you want to go into, I have had fellows do a research project. If they were getting it published, there tended to be work going on after they completed fellowship during the course of their next job. And a couple of folks that have been successful there. But I think, there are also other fellowships in research as well. So I think that's something that you could leverage. And, that's a pathway that we have at University of Wisconsin as well. A lot of times they'll want you to do that in sequence rather than trying to blend them, but that can be an option. So I'm sorry, but by way of a really long-winded answer, I think I'd be surprised if there were programs that placed, front and center, priority on research. It's going to be impressive if someone is coming to the program, with publication, particularly if it's related to addiction medicine. But I think some of those other pieces of evidence around dedication to the field, the clinical work, and service to the population are probably more the things that are going to rise to the top.
Another question came in. Thanks, Randy. On what opportunities are there for perinatal addiction medicine fellowships? So, I'm a pediatrician, of course, and this is important work. There are perinatal addiction opportunities within most fellowship programs. Oftentimes it's done on elective time. There are also several adolescent-based addiction medicine fellowship programs. Penn State and Boston Children's Hospital comes to mind regarding that question. Maybe one for you. There's also a perinatal track at Penn
Right.
as well.
Yeah, Tim, you probably know better than I, but there are programs that sort of came into the mix and became accredited where that was kind of an area of emphasis for them. One that comes to mind is Swedish in Seattle. I don't know if that's still their bread and butter, but I know that they had a lot of experience kind of in that space. And are there other? I'm trying to remember the number of other fellowships that are housed in OB. I mean, are there fellowships that are housed in that clinical department, or?
I think that's the only one at the moment, though. I had an OB-GYN fellow several years ago who actually stayed on and did a research year and now runs our perinatal OB program. And
Right.
it's kind of like the only way to start a service is to go through a fellowship and then start the service yourself.
In Wisconsin, there's a Project Periscope over in Milwaukee at the other medical school. They just started a fellowship in the last year, I think it was, right, Tim, that they got accredited. So I'd imagine that there will be connection there. And so, it's worth sort of checking the different programs and how strong those connections are.
There's a question in the chat from Dr. Yearwood. If you hear me, go ahead and unmute yourself, my friend. Hello, Dr. Yearwood. I think you have a question about some dilemma you're facing. Please go ahead. But I see your. Go ahead, please.
Yeah, it looked like above that he was the same that was asking about board certification in underserved and rural areas, given challenges with access and barriers there. And I'd say, honestly, that's a great place to go with your training in addiction medicine. I think we've been alluding to working with individuals who are underserved, and a big part of taking better care of them is co-locating services. right? If I'm a primary care provider, I haven't had this training and I'm seeing someone with, for example, an opioid use disorder, and I'm sending them to a gastroenterologist or an infectious disease specialist for their Hep C treatment, and I'm sending them to an opioid treatment program for daily methadone dosing, their outcomes are not going to be as good on any of those counts as if I'm treating them in my own practice. And that's also the kind of training that addiction medicine clinicians will often be getting um, is training around some of those common co-occurring issues, such as mental health issues, hepatitis C, chronically painful conditions, things like that, where we know you can address a lot of those issues in primary care and treat them well, particularly if you're co-locating those kinds of services.
Thanks, Randy. Question in the chat from Dr. Uguoke. Sorry if I mispronounced your name. It says you mentioned addiction medicine fellowship being very homogeneous around the country. What do you think program being methadone heavy versus bupe heavy for MAT? No one program seems great and all for fellowship applicants like myself. I'm sorry, I think you have totally misunderstood me. I said it was heterogeneous, not homogeneous. It's like the opposite of homogeneous. So the fellowship programs look very different around the country. I would say most, if not all, will be prescribing the FDA-approved pharmacotherapies for opioid use disorder. But because of the training frameworks, not all programs like our standalone addiction medicine treatment programs, et cetera. Yeah, so feel free to rephrase your question if I've misunderstood. Apologies.
Yeah, I expect there's variation in the exposure to methadone treatment. And Tim, correct me there. I don't think there's like an explicit requirement around number of weeks or days of exposure to methadone treatment in particular. So programs do have some room to maneuver so far as how much training their fellows can get, but important to get some exposure to, so worth asking programs about specifically.
Sorry, I wanted to rephrase my question.
Oh, go ahead. Yes, please.
Yeah. So I'm a second year resident. I'm interested in applying addiction medicine this July. And there are a lot of questions in my mind. I do not have mentors in my program to guide me in a lot of things. I'm like the lone person applying addiction medicine. And I have this concern about acceptability and where to go for like a comprehensive training program, because I've heard that some programs may offer more of methadone exposure for opioid use, and the other may offer more of bupe or Suboxone treatment for OUD. So in that case, afterwards, just prospects remain very like constrained to what you can apply for and what you cannot apply for. So I'm wanting to gain your recommendation on that. And I also have a second question about, I was the one that sent in the job prospects question. For people that have mentioned that are applying to addiction medicine, they're like, roll their eyes and like, good luck with that. I don't think there are jobs out there. There are folks that really are concerned that primary or specific addiction medicine jobs are not longer there. I know you mentioned there are a lot of is a need area, is a high need area, but a lot of jobs that are desirable are not really there. And that kind of bothers me a little. It's not something that will deter me from my application, because I have a very genuine interest in the area, but I just wanted to have your view on that. And then lastly, there was this recent publication about a very dedicated physician in Louisiana who was, I don't know, who was kind of sacked from her job because of some kind of the way people didn't like the way she practiced addiction medicine. There were like divergent views on what happened and what was right and what wasn't right. So this other thing like also raises my worry about like the career. What is like the security and the protection? Am I gonna be safe? Am I gonna be like the future? Is it something that I will do long term, be happy, and without having people on my back wanting to sue me or something like that? So these are some of the things I want to be addressed. Thank you so much.
Thank you for sharing that. I guess I would reassure you on the job prospect side of things that I think an addiction medicine credential, frankly, like any subspecialty credential, allows you to differentiate yourself in what is oftentimes a crowded workplace these days for physicians who just have a primary specialty. And so it gives you kind of I think, a leg up on those types of applicants. But of course, you can only do it if you're interested in it. Without knowing the specifics of this Louisiana case, I'm afraid I can't comment more about it. But I certainly, addiction medicine is a career that is, not known to a lot of different people. So it's not uncommon for applicants to be the only person that their residency has ever had be interested in addiction medicine, and that can be kind of a lonely place. So I would encourage you to reach out to program directors at programs you're interested in, as well as kind of getting involved in some meetings. And then the last thing I'll say about the OTPs, and Randy, feel free to jump in, is that if you're particularly interested in working at an opioid treatment program, make sure you go to a fellowship program that has those exact rotations. We have, for example, 3 blocks of OTPs at Mount Sinai, but not all programs do that. And so maybe seek that out. Randy, any other thoughts?
Yeah, so on the like being disciplined for practice front, really that's kind of a matter of doing your due diligence with documentation. Like addiction medicine clinicians are no more likely to be sued or brought up for malpractice than other specialties, and actually are probably lower risk for the tragic reason that the people that they serve tend to have less access to legal resource. So far as the job market, I think our experience has been that it hasn't been an issue. And I've been really proud to see the variety of settings that our fellows go into. Again, our fellowship is housed in family medicine, and slightly more than, but I'd say maybe a little more than half of our trainees have been family medicine trained, and the rest have been primarily internal medicine. They've gone to a really solid variety of places. A little more than half have gone into sort of a primary care practice where they maintain some mix of primary care plus addiction medicine, with either the addiction medicine mixed into their panel, or they'll have dedicated half days for their addiction medicine patient panel. Probably, a good chunk of the majority of the rest are actually medical directors or medical clinicians in specialist treatment programs, and that's what they're doing full time, and they chose to do that. And then we've had a handful, probably about 10% of our graduates, to go into academic positions. So there's been a really nice mix there, and I think it doesn't close doors. And we haven't had any fellows over our 15 years that were languishing for months waiting for the right job. People are getting it pretty much right out of training.
Thank
All
you.
right.
Thank you.
Thank you. A question from Dr. Williams. When looking at experience, are programs looking for experiences during residency, or is it possible to draw on experiences from life prior to residency and medicine to demonstrate interest? I would say whatever you can draw on is great, in my opinion. I didn't have much in residency. I did a fellowship program after residency. I didn't have much in my residency to talk about. I had a lot to talk about from my personal life, and felt comfortable doing so. Randy, any thoughts on Dr. Williams' question?
No, I'm really glad that you asked that, because definitely there's sort of a term that I hear in kind of, program director circles beyond addiction medicine around distance traveled, just sort of experiences that a person has had in their lives, be it in their medical education or outside, that may bring to bear on their, experience and their dedication to the field. So that's definitely something that the directors and faculty will have an eye to, and is something to be touted in applications. Yes.
Perfect. Thank you so much for answering that question.
There's another question that came in. What are the day-to-day challenges of addiction medicine, and what are the joys? I'll go first. It's medicine like anything else, and I'll be honest, there are some bad outcomes. But being part of people's recovery is such an incredible experience. I never thought I would get so many hugs as I've gotten in addiction medicine. And earlier today, I got a notice that a patient of mine who's really been struggling checked into an inpatient program over the weekend, and I thought this gentleman was going to die, frankly. And so when you're around these experiences, it really does bring up a lot of joy. And there are still kind of challenges for us to kind of incorporate ourselves within the health system. I'm always battling for space and battling for FTEs, et cetera, but I consider it a kind of worthwhile fight. Randy, any thoughts on that?
I think I have sort of like a joy challenge that's sort of one and the same, in that I think we have a lot of opportunity in addiction medicine to engage in systems change to treat people who use more effectively. I think the old model of give the clinic a call and we'll get you an appointment in 2 to 4 weeks and we'll refer you to this specialist who might see you in 6 or 8 weeks is not doing a service to people. And we do a lot of work to try to meet people where they are in ways that are different. And when we're successful there in innovating and doing things like creating a low barrier clinic with walk-in slots for people with opioid use disorder, or a clinic where I'm seeing people with alcohol use disorder and related liver disease, in collaboration with hepatology and behavioral health, like that's fun. I mean, that's really amazing, and people really appreciate that. Again, sort of bringing those services to where they are, and not sort of sending them all over the community is really, really enjoyable. And the patients, yeah, I'd agree with Tim. I mean, getting to know people and their stories, just given the aspects of life that can run with the use disorders. I mean, you really learn a lot about people, and you need to learn those things in order to treat them effectively, establish that rapport, and get things in a space where they trust you and they're going to come back. And that's all, to my mind, a wonderful part of the work. There's tragedy there, but it's really rewarding as you're working on those things with people.
Other questions from anybody on the Zoom? Happy to answer them. I'm going to drop my email in the chat. If folks have questions after or want to reach out privately, they're welcome to do so. Question from Dr. Seelam Neni. Sorry if I mispronounced that. How much of your practice incorporates psychotherapy-like conversations, and do you see that changing as the field evolves, especially with psychedelic-assisted therapy on the horizon? I'm an FMPGY1 interested in incorporating some of these techniques. We are the most, addiction medicine is the most psychiatric of the medical specialties. It's probably the most medical of the psychiatric specialties. So many of us probably were folks who were considering psychiatry careers before we went into our respective programs. So I would say our practice does look a little bit like psychotherapy, maybe not classically so, like people aren't like, lying down on a couch to talk to me, but there's a lot more conversation happening in our clinics than in your typical internal medicine clinic. I think all of us in academic addiction medicine are intrigued by psychedelics, but we have a bias towards peer review and evidence-based medicine, and so we're kind of waiting for the evidence to come out. I think a lot of the excitement and hype has sort of preceded some of the data readouts. So be interested in the years ahead. Randy, any thoughts?
Yeah, and no, I'd agree with you there, Tim. As someone who's involved in psychedelic clinical trials, I think, yeah, there's some exciting early evidence, but we still have unanswered questions around implementation and things. So that'll be something for us to keep an eye on as these compounds achieve FDA approval in the next 2 to 3, maybe 5 years. And I think I don't know. It'll be interesting to see where psychiatry and addiction medicine land with those things. With use disorders being a major area of investigation with some of these compounds, I would hope that addiction medicine and their behavioral health colleagues would be in the mix there. And to some extent, I say that because there's been examination, and I don't know if Tim, if you have updates on it, but I mean, addiction medicine has been part of the conversation and discussion around liberalizing access to methadone, where it could be prescribed by a clinician, but it would need to be someone with the addiction medicine or addiction psychiatry board certification. So there are those opportunities for our field too. I mean, is that something that's been moving forward much yet, Tim, or is it still kind of?
Yeah. So the act's called MOTA, M-O-T-A, and you can check it out. It does have bipartisan support, and everything we've heard has been pretty positive as it kind of trickles its way through the system. Folks, we're almost at time. I want to thank you all for joining this discussion today. Some great questions, and please reach out to us on email if you've got any, and don't be bashful. We like to hear from folks. And as a final note, if you haven't already, we do invite you to join ACAAM, as a trainee member. Trainee membership is $59 for the academic year and includes access to ACAAM's full suite of live and recorded didactic curriculum, along with opportunities to connect with colleagues across the addiction medicine field. You can scan the QR code or go to the website. And if you join today, you'll receive 2 months free, and your membership will extend through June 30th of 2027. We are glad to welcome you to the ACAAM community. All of you are on the right track, and you're not alone, even though it can feel that way at your institution. So please reach out to us, and thank you again for being here, and have a great day.
Thanks, everyone.